Thank you for joining us for Orthopedic Specialists in Sports Medicine's first quarterly educational webinar on hip and knee arthritis. Tonight's speaker is Dr. Eric Erb, OSSM orthopedic surgeon. Dr. Erb is a fellowship-trained orthopedic surgeon specializing in adult reconstruction. He completed his adult reconstruction fellowship at the Mississippi Sports Medicine and Orthopedic Center and his orthopedic residency at Wright State University. Dr. Erb's subspecialty training includes partial and total knee replacement, robotic knee replacement, total hip replacement, revision hip and knee replacement, and outpatient total joint procedures. Please type questions in the Q&A box below, and Dr. Erb will answer questions following his presentation. Dr. Erb?
All right, thank you very much for the introduction, Heather. So let's see if this share screen works. All right. Can everyone see the PowerPoint?
Yes.
Okay, good. So I'm Dr. Eric Erb. Again, all she said about the introduction about me is true. So did my training at Wright State, then finished up in a fellowship in hip and knee replacement down in Mississippi in Jackson, and now currently at OSSM. I've been there for about a year now. Do general stuff, but focus more on hip and knee replacement, and that is more commonly seen in the aging population. So here's a talk going over some of the highlights of that. And we'll just go through some background, so common symptoms, who gets arthritis, what that feels like, predisposing factors that can lead to arthritis, and then options for what you can do for it, both surgical and non-surgical treatments. So we'll always try and do non-surgical things before we jump into a surgery. And then we hit some of the highlights and talk a little bit about some of the nuances of surgery. And then, of course, we'll answer any of your questions. So this talk will probably go 20 to 30 minutes or so, around there. And then hopefully we get into some of your specific questions. And thank you to everyone who's tuned in. So a little bit about myself. I'm from Worthington, Ohio originally. I did my college at Case Western Reserve University, and then med school and residency were both at Wright State down in Dayton. So spent about a decade down there, and then finished up in fellowship, specifically focusing on hip and knee replacement at Mississippi Sports Medicine and Orthopedic Center. Some of the highlights of that program is that I focused on robotic total knee replacement and anterior approach total hip replacement, which are some of the specialty ways that you can get hip and knee arthroplasty done that I have now gotten a very good experience and education in. So currently at Orthopedic Specialists in Sports Medicine located in Granville. Yes, I focus on hip and knee replacement and arthritis, but we treat all orthopedic problems, and we do have an urgent care. So we do have the ability to see you same day, which is pretty unique in this field. So when I'm talking about hip and knee pain in the aging and the elderly, what I'm really talking about is arthritis. It's number 1, 2, and 3 most common cause of hip and knee problem in this population. It is the number 1 most common cause of disability among the elderly in the population. And 1 in 5 adults has been diagnosed based on the CDC. So that's over 50 million people. This data is old. It says 53.9% of adults greater than 75. I would wager that number is a little higher, given the fact that we're seeing this become more and more of a problem. And we're actually getting better and better at diagnosing it as well. So what is arthritis? Why does my hip or my knee hurt? Well, in a healthy joint, in a healthy knee or a healthy hip, the ends of the bones have this kind of cushion or cap of cartilage at the ends of the bones. And so this cartilage that you can see in these pictures here covers the ends of the bones. It's like a cushion that lives there. It's like the tread on your tire. So it allows you to move, to flex and extend, and to rotate through the joint without any pain through the knee or through the hip. Over time, this cushion tends to wear out. And so as you get this kind of wear and tear of arthritis, you get these little potholes initially in the cartilage, and then you also develop kind of full thickness cartilage lesions. And as this cartilage goes away, those bones get closer and closer together. When you have less cushion, obviously it stands to reason that you're going to have more pain. So there's not a lot of nerve endings in cartilage. You can't feel it very much, which is why when you have a healthy knee or a healthy hip with full cartilage, it doesn't hurt. But when you lose that cartilage, the bone does have a lot of nerve endings in it. And so when you get the bone on bone level of arthritis, it is pretty uncomfortable. In addition to the loss of cartilage, you can also develop these little bone spurs. And so that's what this pictograph is meant to be showing here, these little nodules here. And so these osteophytes, or bone spurs, as you heard of, develop as the body's response to losing cartilage. So as you lose cartilage, the body tries to recreate more cartilage, but it cannot. It can create these extra bone spurs. So you get this reactive bone formation. And what happens is as these spurs grow, they tend to decrease the space between the joints and they can cause pinching in certain ranges of motion. So usually you start noticing it in extreme range of motion. For a knee that has bad arthritis, you start to lose the ability to fully extend your knee. So you get this kind of flexion contracture and you can't bend it as far either. So some people end up not being able to bend it past 90 degrees, which causes difficulty, even going up and down stairs. For the hip, when you start to develop these bone spurs, what you notice most is pain with internal rotation. So if you're sitting in a chair and you try and move your leg and your foot away from the midline of your body, you find it difficult to do so, or you have less motion on one side than you do the other, and you get this kind of pinching, sharp pain. So those are the things that we're looking for when we're getting an X-ray of you, is we're looking for these signs of joint space narrowing and bone spur formation, which can lead to the diagnosis of arthritis. So, what does arthritis feel like? It's a chronic, achy pain. Generally, it starts off as a dull pain. It's usually kind of intermittent in nature. So, you'll have flares where sometimes it gets really bad and then it gets better. And they think, okay, that's part of the past. And then later on, whether it's a change in the weather or you end up doing too many chores on a weekend day, you start noticing that pain coming back. And so, it's this kind of cyclical uh, pattern that tends to get worse with time. So gradually it ends up getting more and more severe. You do get some swelling on the knee, which can in of itself cause pain as there's extra fluid on the knee. When you try and bend your knee, the amount of potential space in your knee joint decreases. But when you have fluid is not compressible. So when you bend the knee, that fluid pushes against the sides of your knee capsule and it causes pain. Along with this, you can also get some stiffness that goes in line with the lack of space in the joint and the extra bone spurs. So you lose full flexion, full extension of the knee, full extension of the hip, and rotation of the hip. And then the joints can lock up on you. And so this becomes a problem in activities of daily living. So trying to sleep, trying to go up and down stairs. Sometimes you end up having to go up and down stairs 1 foot at a time, as opposed to just doing it one step at a time. And talking about contributing factors to arthritis, it's a wear and tear disease. So as you age, the more you are wearing and tearing your joints, the faster this can happen or accelerate. Increased weight through the knee. So if you have a little bit extra weight on you, or if you're BMI is 35 or 40, you're sitting there um, putting on 40 or 50 pounds over the last couple of years, then yes, more weight through the knee or through the hip puts more pressure through the hip and it can cause this problem to accelerate faster. As well as the activities you do or the job that you have, a pipe fitter or someone who's laying bricks up and down on their feet and up and down on their hands and knees all day, mechanics, that can accelerate the problem. But really, we have found that there is a strong genetic component to this. So if you've had a sibling that has had this, or if your parents had this and were dealing with this problem when you were younger, then feel free to blame them because there is a genetic component to it. And then anytime you've had repeated joint injuries in the past or previous surgeries in the past. So over time, the more insults that happen to your hip or to your knee can predispose you to getting this problem or having this problem come on sooner than it would have otherwise. So had a previous ACL injury when you were playing football in high school, whether or not it did get fixed, or it had a meniscus tear 10 years ago that had a little knee scope and got it cleared up. Those things all predispose you to this problem happening more rapidly. Interesting enough, women have actually been found to be at a greater risk for arthritis in men. So this study was about a decade old, but it's found that 2 to 8 times more likely than for women to have arthritis problems than men, specifically in the knee, and a 36% higher incidence rate of hip osteoarthritis. Again, this number is also old, so it's at about right around 800,000 knee replacements are performed each year in the United States. I would be shocked if that number hasn't doubled by now. It's just really blown up in the last 10, 15 years. Common symptoms. So, you hear about pain first and foremost, absolutely. Pain that wakes you up from sleep, pain that causes difficulty going up and down stairs, or pain going up and down stairs, most especially going downstairs, that last 20% when you're putting weight on that bad knee and you're going to step down with your other leg. That's when people notice it. Or after a certain period of time, if you used to, walk 2 miles a day, that last quarter mile might start to become a little more bothersome, and then you notice it more and more, and then it tends to progress. But really, what we end up seeing is pain that causes inability to perform your activities of daily living, so normal living, chores, activities, exercises, things like that. We talked about stiffness and swelling being a common problem. You lose motion, which also causes pain. Swelling itself causes pain. And then at the end stages of arthritis, you actually get deformity. So in this picture on the left here, you can see a gentleman who's had his right total knee replaced and his leg is nice and straight, but his left knee's got a little bit of bow-leggedness. And so that comes from arthritis on the inside of the knee, which is the more common type of osteoarthritis. And so as you get more arthritis on the inside of the knee, you lose space over here, you still maintain some space out here, and it slowly pushes your knee outside. And so you end up with this we call bow-legged deformity. And when it gets really bad, you end up starting to degrade the ligaments in the knee, and people can walk and they can see their knee jut out to the side with every step. It kind of thrusts out with every time you put weight through it. So that is something that can get worse more towards the end stages of arthritis. And it's not just bow-leggedness. If more of your arthritis is on the outside of the knee, then you can develop kind of a knock knee deformity, which can be frustrating and annoying. So how do we diagnose it? The easy answer is to go see an orthopedic surgeon. We take a good, thorough medical history to see maybe what predisposing factors you had that caused this to happen in the past, how long you've been dealing with it, what have you done for it, et cetera, et cetera. We get an x-ray so we can look at all those things that I had mentioned before. And so this picture on the left, you can see nice healthy bone, nice smooth edges, good space between the bones, looks pretty uniform, as opposed to this picture on the right where I know it's blurry, but you can see very significant joint space narrowing. There's in fact no joint space between the two bones here, so you're getting this bone on bone grinding, and then kind of this fuzzy outline of the edges of the bone. So those are the bone spurs that are developing over time. And those things coupled with a physical exam to see where it's hurting you, whether it's consistent with arthritis, whether the exam matches with your x-ray, are all ways that we can use to diagnose arthritis. Rarely do we need to get a CT scan or an MRI, and usually that's just for a very unique patient. Some of you may have heard of rheumatoid arthritis and wondering if that's something that you may be dealing with. Rheumatoid arthritis can present with similar symptoms as osteoarthritis, but the pathology, like the source behind the problem, is very different. So it's much less common, only about 1% of the US population. And it's a chronic inflammatory response. So it's actually your body's immune system being overreactive and attacking your joints because they think it's a foreign object. So it attacks your joints, which leads to all the inflammation symptoms, so the swelling and the pain and the warmth, without as much of the x-ray findings. So you really don't see significant x-ray findings in rheumatoid arthritis until much later in the disease, as opposed to osteoarthritis, where it is a wear and tear disease that ends up happening as a degenerative problem over time. So generally, we see rheumatoid affecting people at a younger age as well. So, how do you treat arthritis? It can be managed, it can be replaced. We have yet to find a cure for it. So, in terms of growing back cartilage or getting your knee at what it was at 18, there hasn't been anything promising on that front. But there are ways we can manage your pain, and then when all those things prior to surgery no longer work, then we discuss surgery to replace the worn out cartilage with metal and plastic implant. So, from a non surgical standpoint, things we start with: lifestyle modifications, assistive devices, physical therapy, anti inflammatory medications, and injections. So, lifestyle modifications is diet and exercise, trying to be active, trying to find ways to exercise that don't hurt your knee or your hip, which can be challenging when that is the thing that maybe causes you to start having pain in the first place. And so, if walking was the thing that you used to be able to do, but now no longer can't do, sometimes it's finding maybe aerobic therapy or other ways that are even more low impact than walking, such as getting on a bike or a recumbent bike, or getting in the pool. And that's where physical therapy comes into play as well, because they have good exercises that can help you exercise without putting weight through the joint. And then if we need to progress to a walker or a cane, sometimes those are options as well. And weight loss is always a good option if you are overweight and dealing with these problems. Physical therapy really focuses on quadricep muscle strengthening. It doesn't fix the arthritis, but what it can do is give the leg a little bit more stability, which can lessen the symptoms of arthritis. If your knee is stronger, you can use the muscles to kind of offload the joint a little bit. And the way that they do this are with these low impact exercises that, again, strengthen your quad, but are not putting weight through your knee. From a medication standpoint, usually we start with oral and topical anti-inflammatories. So your ibuprofens, your Aleve, meloxicam is a common one that's a little bit stronger, is a prescription strength that a lot of people find beneficial. And then topical gels like Voltaren gel or diclofenac gel are NSAIDs that you can rub on the skin. And sometimes that is a better option for people that can't take oral anti-inflammatories, people that have kidney problems or have allergic reactions to NSAIDs, things like that. When those no longer work, we generally step it up to an injection. Steroid injections and gel injections are both offered at our office. The steroid has a little bit more research out there that demonstrates its effectiveness. So usually that is my first line for an injection, but some people can't tolerate them, they don't work, or if you have uncontrolled diabetes, sometimes putting extra steroid into the body is a bad idea. So for those people, we we'll switch them over to the gel to see if it works. And the two function very differently. The steroid is an anti-inflammatory. Again, it's just a much stronger concentrated dose inside the knee, whereas the gel injection is just a very thick, viscous liquid that allows us to put that into the knee, which kind of creates extra cushion in between the bones. And that's how people find some effectiveness from that. When should you consider surgery? So, for the short answer is when everything else fails, when other treatment options are no longer working, when it hurts all the time. You've tried the injections, you've tried the pills, you've tried the therapy. When you can't do things, when it's waking you up from sleep at night, when it's just a constant problem, and when it starts to affect your quality of life. That is the goal of the surgery, is to get you back to what you were doing prior to having this problem. And a lot of people, maybe the most common thing I hear once they've gone through the process of having a replacement, of having a surgery, is they look back and they say, I should have done that years ago. And there is an appropriate hesitancy to needing a surgery, especially one as big as a total knee or a total hip replacement. But when the problem is arthritis, then it's really the only definitive option. Everything else tends to be sort of a band aid or a short term solution that keeps on having you come back to the doctor. So when we're getting into some of the more nuanced answers, okay, what type of surgery is best for me? There are a couple of different options out there. So from the knee side of things, you can get either a partial or a total knee replacement. And while there is a partial hip replacement, it really doesn't have as good of a footprint for this patient population. It's really something done more um, for like the elderly with hip fractures, and the total hip replacement is really the best option when it comes to hip arthritis. So a partial knee replacement is when you only have a disease, the arthritis disease in a certain portion of the knee. Again, the most common place to get knee arthritis is on the inside compartment of the knee. And so a partial knee replacement where you're just replacing that one section of the knee tends to alleviate all the problems of arthritis as long as the rest of the knee looks good. And it's a faster surgery, it's a quicker recovery, and the knee feels more natural for you. So it ends up being a quicker surgery with a quicker recovery. And for the right person, for the right patient, it's a great option. The most common type of knee replacement is a total knee replacement. And that's usually because the most common type of osteoarthritis is one that affects all three, or at least two of the three compartments of the knee. And so when you do that, when that is the case, you end up replacing the whole knee. So you're cutting the edge of the femur off and you're putting kind of a metal cap over the edge of the femur. That's what you're seeing here. And then you're taking the top of the tibia and then you're putting a tibial, base plate here into the top of the bone, and in between those two is this little piece of plastic here that really allows you to get that cushion between the pieces of metal and gives you extra and appropriate stability, because we are able to use varying levels of implants and sizes of implants to really allow your knee to get full range of motion, but also have very good, sturdy knee with strong stability. From the hip side of things, a total hip replacement is the far and away the most common surgery for hip arthritis. And so, what you end up doing during this surgery is you make a cut in the femoral neck right there. You take the whole diseased head out of the hip, and then you put a little metal cup inside the pelvis right there. And then inside of that is a metal piece, or sorry, a plastic piece here. And then on the femoral side of things, you put a little stem down the femoral canal, which allows it to get good fixation there. And then your little ceramic femoral head here fits inside the liner. And so the movement of the new hip is between the femoral head and the liner. And so it allows you to get really good motion without any of the pain that you were having from the grinding and bone on bone articulation of a diseased hip. As I said before, the anterior approach is one that I utilize. And so there are multiple ways to get into a hip from a surgeon's standpoint in order to do a hip replacement. The anterior approach is a little more new, and people have found very good results. It's a quicker recovery generally because you go in between muscles. You're not cutting any muscles off of the bone and then repairing them. And so people tend to do better faster. You also have a decreased dislocation risk. Again, if you get a posterior surgery, which sometimes is necessary, but usually I try to go from the front if you're a good candidate for it. If you go from a posterior approach, then you have to take some of the tissues off of the bone, and therefore, after the surgery, the patient is limited in terms of which directions they can move for about 6 weeks. So, in terms of no crossing your legs, no bending your hip or leaning forward with your hip bent, because all those things can increase the risk of you dislocating after the surgery as those tissues are healing that you had to cut. None of that's a problem from the anterior side. And so you get a little incision over the side of your leg, and people are up and walking right away without any restrictions from the surgeon, which is very nice. And people have been very very gracious and very glad that that's been the case in my practice. From the success of hip replacements, it's probably my most favorite orthopedic surgery. People just do really well, really fast, and we're really glad with how their surgeries have gone. It's one of the most common procedures performed in the U.S. Again, I would wager that number is as low as 230,000 every year. And it allows you to get back to doing the things you couldn't do before, so walking, stairs, sleeping, getting in and out of a car, and it takes care of that immediate sharp hip pain that you're seeing with arthritis. Takes care of it immediately as soon as you wake up. I have no restrictions after surgery. As soon as you wake up, I get you walking with a walker, going up and down stairs. And usually this is done on an outpatient basis. So people are going home same day. Revision hip and knee replacement is a little less common, but I just wanted to include it in here as an option so that you guys are aware that if you've had a previous hip or knee replacement, but it is still painful, then sometimes it might require an additional surgery. So things that can cause a previous hip or knee replacement to fail is infection, a loose implant, or if the implant is malpositioned, sometimes it can lead to pain and may need a replacement, a secondary replacement. So there are ways to help you both operatively and non-operatively. Usually that requires a revision replacement with a larger implant, but that can be the case. I'd say the thing that's probably changed the most with hip and knee replacement over the last 15 years has been the operative experience of the patient. So there's been so much research out there. It's become such a popular surgery because it does so well that people are really invested in trying to make it even better. And we have seen those changes happen in leaps and bounds. So prior to COVID, a lot of these surgeries were done inpatient. And when I was starting my training, really all of those surgeries were done inpatient, which means you were staying in the hospital for 2, 3, 4 days. Now, I would say 90 to 95% of the surgeries that I do are done on an outpatient basis, which means you're going home the same day you're having the surgery. So that means you get to do your surgery at a surgery center for the most part, as opposed to a hospital. So you're not around sick people. You're not at risk of developing some of the complications we can see from just being in a hospital setting. We have a great anesthesia team that can give a good, like, they give you a nerve block in your leg prior to the surgery so that you have good pain control in those first 10, 12 hours after the surgery when your pain would have otherwise been at its highest. That nerve block really helps people recover faster, um, and you get a faster recovery. So, again, I have no restrictions after the surgery. I'll get you weight bearing right away. For the first 2 weeks, I have home health come to your house and work with you a couple of times a week just on getting up, making sure you can go to the bathroom okay, checking the incision, checking the dressing, doing some very basic exercises. And then at that 2 week, that first visit I see is 2 weeks after surgery. We get the dressing off. There's no stitches that have to come out. All the stitches I do are absorbable, and I use skin glue over them. So it's just making sure everything looks okay. And then we set you up with physical therapy. So your first physical therapy visit lines up with your first post op visit for me. And then you get to start working with our therapists, which allow you to get working on motion appropriately soon. I don't need you to start moving too much too fast when you're swollen after surgery. Sometimes the first few weeks can be beneficial to just kind of take it easy and work on swelling control and pain control. So recovery again can start immediately. Most of these are outpatient. I will say this is a very patient-specific recovery. Everyone recovers on a different pace. I make that very clear. The 45-year-old that ends up having arthritis from having previous injuries as a kid and then has a post-traumatic arthritic hip is going to recover faster usually than the 85-year-old on a walker with poorly controlled diabetes, who's maybe got a little bit too much weight on them. So those are two different people that recover at different paces. But I've had some people surprise me and do very well very fast. I had a patient 2 weeks out from a knee replacement, came walking in without a walker or a cane, had zero pain, and I haven't seen him since. So the people do well. Generally, it takes about 6 weeks to recover from a total hip replacement, about 10 to 12 weeks to recover from a total knee replacement. I think physical therapy post-operatively is a very important part of getting the maximum we can out of our surgery in terms of how much motion we get afterwards, and how much function you get in your knee or your hip, more especially in the knee. The knee really does rely on physical therapy to get as much motion and strength as we can before that scar tissue really solidifies. So, in summary, hip and knee pain is a very common problem. Many people tend to delay treatment just because they're hesitant around surgery. At this point, there's been so many new advances in the surgical process. A lot of people that I have seen that have kind of approached it hesitantly have been very impressed at how efficient the surgery is, especially if it's at a surgery center. And so, it is a good option. I'm happy to talk to each and every one of you. I treat this patient specific. Your treatment is specific to you and to your social situation and to your problem, and then what you want to do. Ultimately, it is your joint. I'm just here to give you my medical opinion and advice. Some other resources. I know there's a lot of misinformation out there, but these are three trusted resources that have great web pages for patients. So the American Academy of Orthopedic Surgeons, Arthritis Foundation, and the American Association of Hip and Knee Surgeons are all three very good websites that have information that can allow you to kind of get a better idea. If this talk was anything, those also provide good information for a problem like this. All right. Well, that was the entirety of the talk. Hopefully, I didn't bore you too much. Now I will take any questions that you might have.
So the first question is, what does my BMI need to be to have a joint replacement?
That's a good question. I don't have a specific BMI cutoff. That's the truth, although it is patient specific. I mean, even if you're in like the low 50s, we used to have a cutoff of 35. Since then, there have been some studies that have shown people that even have a BMI over 40 or are morbidly obese still do well from a surgery and can benefit from a hip or a knee replacement. So, while more technically challenging for the surgeon, that's not a reason not to do the surgery. It is dependent on other factors as well. So, if your diabetes is poorly controlled, or you're smoking cigarettes, or you have other heart problems, that will sway the decision that I make and maybe end up having you drop a little bit further. But I don't usually have a BMI cutoff. But once we get into the 50s, then I take a much more serious look at it, because also depends on where you hold the weight, whether it's over where the incision is going to be, or if it's more central obesity, and so all those play a factor.
Can I have both knees done at the same time?
Yes, you have to be very motivated to do so. So I have done it before. I make sure that you are aware of how uncomfortable that is after the surgery. So it is something that I generally try to avoid. But if you are very motivated and you want that to be an option, then yes, I will do that. Just so you for a little while don't have a good leg to stand on.
If I have bone-on-bone arthritis, do I have to have surgery?
No, arthritis. I mean, I've seen people that have had very mild arthritis on X-rays, but it was just killing them. And I treat that person differently from somebody that has terrible end stage arthritis based on an X-ray, but really isn't having that much pain. It's really about how it affects your quality of life. So at the end of the day, when you get really, really bad arthritis, you start losing stability in your knee. And that's a different problem. I'll talk about that with you in the office. If I think, even if you're not hurting that bad, I still think you need a knee replacement or a hip replacement. But really, at the end of the day, it's when you start to notice your scope of life kind of narrow. If this joint affects your ability to live the life that you want to live. It's like, hey, I can't do the things that I want to do. That's when it's like, hey, let's talk about a surgery.
Does Voltaren gel work for hip arthritis?
Not as well, just because the hip is further in the body. It's just harder to get to. So you can try it, but usually it's not as effective as for knee arthritis.
If I need both hip and knee replacements, which should I have first?
Another good question. It depends on which one is worse. So, if they're both equally bad, sometimes hip arthritis can also lead to knee pain. So, between the two, I tend to try and do a hip replacement first. But there are some people that you have both hip and knee arthritis, but the knee is killing you. I'd say, well, why do we do the hip first if the knee is the number one problem? So I have you tell me which one's bothering you the most, and that's usually the one that I do first.
2 years ago, my knee was swollen and painful. I maintained walking and cycling activities and added supplement collagen peptide. Today, I have no pain, just stiffness. Did the collagen play a role?
Maybe. There's probably not enough data out there to say whether or not definitively it helped you. I think you being active probably played the strongest role in your recovery. Um, it's a hard question to answer because there's really no way to know, because the only way to tell would be to also have you not take it and then compare the two. So it's not something that I would suggest for everyone to take, but I'm of the opinion that if you find a treatment plan that works for you, as long as it's beneficial for you, then it's beneficial for me.
What is the recovery time for total hip replacement?
Pretty quick. So we start you off on a walker right away. Usually by the time I see people at 2 weeks out, they are no longer on the walker and sometimes not even on the cane. I would say 80 to 90% of your recovery is in the first 6 weeks. Um, And again, there's differences. Some people do better, some people take a little bit longer, and that's okay. But in general, it's around 6 to 8 weeks for the majority of your recovery.
Do you always recommend PT after surgery? And does OSSM offer therapy?
What was the second part of that question again?
Does OSSM offer PT?
We do, yeah. So we have our own physical therapy group. They're great. Megan and Christian over there and Pat, they do a good job. So I always offer it. I think it is more important for after total knee replacements because we really have to focus on getting motion back when you have that much swelling around the knee. Hips, I do think they benefit from it. So I always include it as part of the post-op package that I kind of set you up with before surgery. But I have found that the knee arthritis, like the knee replacements, are the ones that really lean into therapy more, and the hips tend to graduate from therapy a little quicker.
Can a damaged hip radiate to the knee and down to the ankle?
It can radiate down to the knee. Majority of time when you have hip arthritis, and not everyone's, but most people's hip pain is in their groin. So you get groin pain that radiates down the inside of your thigh and sometimes even getting into your knee. It's unusual for hip problems to lead to ankle pain. A lot of times there's a pretty big overlap between hip problems and back problems. And so if you're having pain all the way down to your ankle, what I would probably do if you were to come and see me is I'd also take a look at your back to make sure that's not a thing that's causing pain all the way down the leg.
That was our last question. Please put your questions into the Q&A box if you have any other questions. We'll wait for a minute. There's no more questions. Thank you very much, Dr. Erb, for your presentation.
Thank you very much for everyone that showed up.
Thank you for participating in tonight's webinar. We hope you enjoyed the presentation. Enjoy the rest of your evening, and good night.